Are we ready? Great. Good afternoon, everyone. Welcome. My name is Brian Scarpelli. I'm the Executive Director of the Connected Health Initiative, and on behalf of the CHI and our steering committee members, thank you for being here at the Hill Center this afternoon. For those who don't know, very briefly, the Connected Health Initiative is a leading voice for digital health policy changes here in Washington, D.C. and before states across the country. We base all that we do on a consensus across those building digital health innovations, clinicians, providers, payers, patient advocates, all around, a consensus we identify across those different groups that are all centered on the idea of the quadruple aim, the idea that for us, digital health tools can and should improve patient outcomes, reduce costs, augment population health management, and support the healthcare workforce. So just a few thank yous to Administrator Oz and the entire team at CMS. Thank you. We are grateful for your leadership in American healthcare, and especially for the vision you've brought to standing up the RHTP, the Rural Healthcare Health Transformation Program. Thanks too to our other speakers and panelists who you'll meet, but thanks to all of you. Providers, technologists, congressional staff are here, advocates, others who have made the time to be here. So just a little framing from me, I promise. I won't go on too much longer. The RHTP is a $50 billion investment that's one of the largest federal investments, commitments to rural health that we have ever seen. And Congress created it to keep care accessible across rural America and to give rural hospitals and providers the infrastructure, workforce, the technology that they need to serve their communities for the long term. And I think that these goals map perfectly onto what digital health tools and services do best, such as remote monitoring that catches a problem before it becomes, there becomes a need for a hospitalization, telehealth that can bring a specialist to a patient who would otherwise have to drive 3 hours, AI tools that will give an overstretched clinician some time back and make them more efficient. So RHTP is our chance, a huge chance for all of us to bring these tools to the communities that need them the most and to do it at scale. I will briefly mention one thing that for the Connected Health Initiative, we've got a pretty strong belief that if we deploy these technologies and we can't show what they did for patients and how they saved and what they saved across the states, then we will probably have missed a larger opportunity. So we need to know what's working and what to keep funding. And to that end, the Connected Health Initiative has developed some recommendations on measures for states to use as they administer and oversee their Rural Health Transformation Program grants, which provide some granular recommendations across a number of priorities: prevention, chronic disease management, access to care, reducing avoidable hospital use, workforce sustainability, financial health of the providers, getting to hard-to-reach populations, deploying technology safely and responsible, including AI. And for each of these ones, we recommend some concrete outcome-focused measures, including on how to document both the improvements and the dollars saved. And I would mention, too, that each of these measures is harmonized with federal measures that exist today that set out, that providers use, such as CMS's Universal Foundation, ARC indicators, AHRQ indicators, that is, and the new and innovative CMMI access model, which we're also separately but also very excited about, and others, because we don't want to reinvent the wheel. So my ask to you all is that you'll engage with us moving forward to improve on this living document, so that when we look back on the RHTP, we can prove how digital health tools produced better outcomes and lower costs and healthier rural communities. We have a remarkable group here to take this further, and it's my honor to turn to our first speaker. It is not every day that the administrator of the Centers for Medicare and Medicaid Services joins a conversation like this one, so please join me in welcoming Dr. Mehmet Oz, the 17th administrator of CMS at HHS. Thank you so much.
Well, the fact that I'm here shows how much we care about this program. Every time I get an invitation to speak about the Rural Health Transformation Fund, I take advantage of the fact that this program, which was created by the President and Congress with a very clear desire to not just pay bills in rural America, but actually redesign how we envision care being delivered in rural America, and maybe learn from some best practices that evolve from this project, ideas that could actually benefit urban America. But to focus on rural America, let's be honest about where the challenges are. First off, life expectancy dropping in rural America. It's almost a decade behind urban America in some spots. There are major challenges to just delivery of basic care, cancer care, autoimmune conditions, things that are a bit more complicated than the norm. They're really a challenge in urban, rather rural parts of the country. And part of the opportunity that we have with this landmark legislation, the most ambitious funding of rural health care ever in our nation's history, was to think very differently about what could be the future of care for 60 million Americans living in rural parts of the country. Now, interestingly, as you think about how the program was designed by Congress, and the details actually do matter, it was purposely created in a way that we would address one big block, which is that we send money from Medicaid to the states and never seems to get to rural America. Only about 7% of federal dollars get past the capital, the big cities, the big hospitals, in the more urban areas into rural America. So $50 billion over 5 years represents a 50% increase in the amount of money going to rural parts of the country over what is currently going there. And again, that's every year for 5 years. You don't put that kind of money to use, again, just to pay off some old debt and make sure that everyone's a little happier. You do it because you have an opportunity, a generational opportunity, to reshape, to reimagine what rural healthcare could look for. So let's pick Stanford Hospital System, a large rural hospital system many of you are familiar with, and the care that it seeks to give, just as an example. And if you're a farmer, and there's one particular example that was in a magazine recently that highlighted this reality. A farmer's out there in his device. Well, I forget what kind of device he was in, but he's in the caboose, and he's trying to get health care. Normally, he'd have to drive, the average in America is 26 miles in rural parts of the country to get to these folks. In places like Wyoming, which I spoke to their leadership yesterday, it's 26 miles is the average. That's a lot of time out of the day if you're a farmer. And this growing season, in this case, it was growing season. They needed to be on the farm doing their job. And the fact that this person actually would drive about 40 miles a day made it impossible to get health care during that period of the year. In aggregate across America, we drive about 40 million miles a year to get access to care. Most of it, of course, those miles are driven by people in rural parts of the country. And if you want to get an endocrinology visit from the combine's cab, which is what happened here, then you actually have to have technology come into the 21st century while we're a quarter of the way through it. And that's actually what's happening now. So Stanford Health is making it easier for their specialists to connect with patients in rural parts of the country, wherever they may be, because it's just as easy to Zoom with you if I'm in my office, as long as you're not coming actually into the office, anywhere you happen to be. So they make that possible. The total amount of money we probably spend just wasted not going to work is in the tens of millions of dollars, estimated last year at well over that, $41 million. And the mileage that the average patient avoids is significant enough that it shows up as a major concern expressed in rural parts of the country. Now, with that as a sort of a framework for the kinds of problems we're dealing with, let's talk about how do we actually deliver care where rural America lives. So the classic story of a hospital that's in trouble is an institution that has been doing well, was built maybe with 100 beds. It's shrunk down to 10-bed census on average, and this year it has a census of 1. If you have a census of 1 patient, what that means is the people inside the town are driving past that institution to go where they actually think they'll get better care. So you don't fix the problem by paying the debts of the hospital with a census of 1. You fix the problem by making that hospital seen as a place you want to go to get health care. Because once you go from 1 patient to literally 5 patients in the hospital, you're not losing money anymore. That's how we win these battles. We actually focus on quality and make it possible, and make sure no rural resident is left out or left on the sidelines as we do this. And so what the Rural Health Transformation Fund says as an example is, can we have a larger institution in the bigger city adopt a smaller institution? And by that, I don't mean take it over financially. I'm saying the doctors at that institution now attend grand rounds with the clinicians at the larger institution. They get best practice updates because they're part of the family now. If you're an OB who's delivering 50 babies in your clinic, a week, and there's a doc who's or a health professional delivering 2 babies a week, maybe you sort of combine efforts, and that physician who's not quite as busy delivering babies learns a bit more, so that when there is a problem, a crisis, the more experienced clinic can reach out and say, hey, listen, you got this. You understand? We talked about this last week in rounds. We had this problem. We dealt with it this way. Or the patient you're about to see is really a concern. We don't think you can manage it. We got to helicopter them out of there immediately. That's how we deal with the ridiculously high infant mortality rate and maternal mortality rate that we're facing in many parts of rural America. And some of the opportunities that we're seeing through these grants highlight some of these issues. So that's an example. But how do you actually scale this? What does it look like? So the way the grant was written, the law was passed on July 4th and signed into law. By the end of last year, we had to get all the money out of Washington. That's really important because the president and Congress felt if we get the money to the governors who know their states better than anybody else, who care about their people, who know their rural areas, they would then be on the hook to do the right thing with the money. We wouldn't have it sitting here in Washington where people could lobby us and maybe direct the money a little differently. So sure enough, working through the holidays, on December 29th, the money was sent to every single state. And those states now have the money in their capitals, in their coffers, and they have already started to deploy them into rural parts of the state. They're making some difficult decisions because they had to make some difficult decisions in the fall to get the money. In the grants that they wrote to us to request funding, they had to outline the kinds of things they would do to ensure that the money would be well spent in their state. If they don't abide by what they wrote, if they don't do a good job getting the money out of the capitals of these states, we will take the money back. Now, that's actually a favor to the governors because the governors can now go to the legislatures or other groups, the insurance commissioner, and say, listen, if you don't fix this problem, we're going to lose the money. I don't want to lose $200 million every year for 5 years. So let's get it right. Mr. Insurance Commissioner, start allowing pharmacists to function at the height of their license, or stop fighting with the insurance commissioner in the other state next to us. Let people live along those rural borders, get care wherever they may be without doctors being restricted where they practice. It's those kinds of powers we wanted to give governors by giving them the money with Hulk attached to it, so we could take it back. As the grants came in, we began to see some very, very thoughtful work having been done. I want to highlight a couple of these proposals because these are the things that are now being funded and being supported. But one of the things that we believe is true is as you get all these great ideas from 50 states, you take advantage of the federal system, which again allows us to exchange best practices. If a state like Alaska, which is very rural, figured out a really cool way of providing maternal care using access to devices like ultrasounds that aren't available in other parts of rural America, maybe they can exchange ideas. We have the same thing happening in Lower Alabama. By the way, in Lower Alabama, they call it LA. They actually have a specific proposal around early detection of problems in moms, pregnant women who are going to be moms, using devices that, again, are fairly novel. In Alaska, because they are so rural, they actually have drones delivering medications to deal with some of the access to just simple medical care that's playing out there. I'm going to give you a few others. I spoke to Wyoming yesterday. They've got a bunch of very clever ideas. Montana, similarly, using electronic health records, which is very germane to this organization. When you have EHR systems that work well, it's incredibly helpful for a bunch of issues, not just the quality of care you're giving patients, but even your ability to do prior authorization, which we believe 90% of the time is going to be done instantaneously if you do this correctly by next year. But you have to be able to get EMR data back to the insurers in order to actually be reciprocal. That's the big hang up right now. The insurance companies have all pledged to deal with the prior authorization challenges of the country, that heinous process where you're talking to your doctor and you need to have this mole taken off to see if it's cancer, and the insurance company says, well, yeah, I know you paid your premium, but we don't think it passes muster. We're not going to let you have the procedure. And 3 months later, you're waiting to see if you have cancer or not. With the prior auth process, the insurance companies have already dramatically reduced the number of people subject to prior authorization, and they have lots of other ideas that they're willing to use, but most doctors don't respond appropriately. They respond with paper. If you're in rural America, it's predominantly paper. And so by moving EMRs into rural parts of the country, these tools now can rapidly interplay with the sophisticated systems created by insurance companies, hospitals, referring institutions, et cetera. So now you have local clinicians and clinics getting access to technology that otherwise might be unaffordable. And the big vendors will sell their products at a discount if it's coming through a large partner of theirs. We've already seen this, and this is part of some of the opportunities that we see out there. In Louisiana, they're giving phones to folks who they believe are at risk, together with apps and AI platforms, so they can actually take advantage of digital support for the decision-making process. So you heard briefly about the access model. It's a CMMI model that allows us for the first time ever to pay for digital tools if they provide better outcomes. So we don't care if you engage people who are smoking. We care that they stop smoking. We don't care if you talk to diabetics. We want them to reduce their A1C. So if you achieve those goals, then you'll get paid more. For the first time, you'll get paid something. And all the major tech companies have now signed up to join us. We started off with 60 of the biggest companies you've ever heard of. We're up to 700 now. And the access, the technology transformation that I'm speaking to, Amy Gleason set up, those are pledges for these guys to participate. The access model allows some of these companies who want to be in this space to build apps, to live on an app ecosystem with CMS, that now they can get reimbursed for the efforts they're making to build these tools. That opens up innovation, it opens up investment, it protects founders of companies who have ideas that they want to get out to the marketplace, but you got to deliver. You got to actually bring a better result to the patients you're taking care of. So when you have CMMI, which is the Innovation Center, working together with the Tech Transformation Group that I mentioned, with Amy Gleason's group, and she's sort of building a center of gravity for engineers. We had less than 10 engineers at CMS when we started. You can't run an agency that controls almost $2 trillion of the US economy without engineers who are actually engaging with the folks on the other side, private sector companies that are working with us. Because otherwise you have a government relations person talking to an HR person. You don't actually have the people who know what they're doing talking with each other. Unlocking that has been a big win for us, and it happened because there was an awareness of the importance of many of these efforts. In fact, I just left a meeting coming here that was organized by this group because we're completely redoing the circa 1979 COBOL-based building system of CMS. I can't even find engineers who know how to program in COBOL anymore. But within the next 3 years, this will all be upgraded, cloud-based, and we'll have much more sophisticated ways of interacting with AI systems, as an example, so that we can begin to reach out and talk to Americans. Now, if we get some of the things that I'm speaking to work effectively, that's the goal. It's not just to be able to send an email once in a while. We take care of over 160 million Americans. What if everyone had an agentic AI that could come out, the tool, that could come out and interact with you based on what your issues are wherever you may live, including in rural America, but you can come back and help folks in urban America as well if necessary, and it was a more proactive, interactive approach rather than waiting for you to get sick and then reaching out to the healthcare system that the government's funding. And I think those kinds of changes are now within our grasp, which is why I think many of you who are thinking about this field seriously might consider coming to work at CMS, which is my ulterior motive for coming today. There's lots of other ideas. Arkansas is sharing services. They're using group purchasing organizations to be able to get economies of scale into the healthcare system. Maine has more school-based healthcare tools. Delaware is building a new medical school in the rural part of the state. All of these states have different ways of taking tools that are now available that the rest of the health system is using and bringing it into the rural ecosystem. If we do this correctly, it will allow us to leapfrog where we are now. So over the next 5 years, we'll be where we should have been when I came into this position. Now, CMS, and it's worth a digression into this discussion of its goals, has OKRs, objectives and key results. And we are very focused on making sure that these OKRs are understood by everybody in the organization, but everyone who works with us or interacts with us should understand them as well. The first important OKR is to be the best payer of all. I say best payer because I want to lead by example. If our team of hardworking individuals, and they are wonderful human beings, who came into government, all mission aligned, they gave up really well-paying jobs to come serve the American people. If we let them do their jobs, they will deliver a better product. And making them successful is part of the goal of making them the best payer. So if they're well taken care of, if, for example, they're learning how to use AI in their personal lives and in their work lives, they'll start to use AI for CMS in a thoughtful way. With appropriate guardrails, if people desire it to be used in their lives, we will be ready to meet you where you are. We also have MAHA as a major pillar. The Make America Healthy Again movement primarily is about curiosity. It's about getting folks who want to know more information so they can make wise decisions, empowering them to make choices for themselves. not browbeating them if they challenge the ecosystem. We actually think that's a healthy thing. Secretary Kennedy has been adamantly supportive of a lot of the things that many folks actually want to have happen anyway, especially in transparency around healthcare. And we have a lot of workflow within CMS because we pay the bills, so we can pay bills differently based on the ability of a hospital, for example, to incorporate the food pyramid into their meal plans as opposed to ignoring it. Same for Medicare Advantage plans, and frankly, many others in the health ecosystem who want MAHA to be part of what they're doing. It benefits them to be part of our administration's efforts. We have great opportunities as well in making sure that we have the tech innovation tools that allow us to go to the next generation successfully, which is why there's been such an emphasis on that, because that makes everything more affordable as well. And affordability is a major crisis right now in our country in healthcare. Not only are we growing our health economy at twice the rate of our GDP growth, which is not sustainable, but the reasons for it are ones that we control. So it's a bad news and a good news all at once. We got a problem. We cannot spend that much more money in healthcare every year, but the reason we're spending it is because most healthcare costs are spent on chronic illness. And chronic illness is disproportionately reliant on lifestyle choices that people make. So, for example, we're twice as expensive as any country to pay for healthcare per capita. We're also twice as fat as any other country on average. We're 43% obese. Europe's 20%. Japan's 5%. So if we actually deal with obesity as a lead cause of hypertension and diabetes, and the downstream problems that happen from those are, strokes, dementia, heart disease, kidney problems, liver problems, a slew of issues. These are all addressable if we get America to think differently about their own health. Some of the problems, however, occur because you can't afford to get the health care that you desire. A good example are pharmaceutical products, where last I looked, I think it was 27% of Americans go to a drugstore and leave empty-handed because they can't afford the medications that they desire. A lot of this can be addressed if we do something that should have been done years ago, which is push the industry, the pharmaceutical industry, to most favored nation drug pricing, which means very simply, we're not price fixing. Whatever you sell these drugs for overseas, you got to sell them for here. Why does that matter? Because on average, Americans pay 3 times more for the exact same drugs made in the same facilities as Europeans and folks in Japan. So we should be paying the same price as everybody else. It's global freeloading if we don't insist on that, and we're not going to tolerate it anymore. And the president's been insistent on changing this, and he's been successful. So we have lots of opportunities to bring costs down, to make it easier for Americans to afford the health care they deserve. That's part of what CMS's job is as well. Let me leave you with 2 final thoughts, because you're a technology-centered group. The first is we want to kill the clipboard and axe the facts. We don't want these to be part of your future anymore. We want you to go to a doctor's office, hold up your phone, have a QR code with all the pertinent information that you never have to fill out one of those clipboard docs again. And if you want it, it'll have your medical records on there. It'll have radiology images, whatever you want to have on there within that QR code or whatever ends up being used on that technology transfer portal. And this is paperless, as the waiting room should be. And using digital ideas and data sharing, this should be eminently achievable within a year. And that's already a very rapid workflow that's making progress. And that, again, makes a doctor's office as seamlessly efficient as it should have been. Your barista should not have a more efficient technology transfer system as your doctor's office. And the second big issue, which I do want to hear feedback from the group on as you have your meetings today, is AI. Most Americans are scared of AI. 2/3 of beneficiaries are worried about AI. They're not sure it's in their best interest. Artificial intelligence and the technologies associated with it could unlock massive amounts of value for the American people, improve their care, and it has risks. It could very quickly take over the way that we take care of the American people and hurt that process as well. I'm confident that if we use these tools correctly and we put humanity first, and not make it the target of AI, but actually the goal of AI to support, then we'll make routine, high-quality care and the norm for our people, and I believe other nations will benefit as well. If these AI-driven tools, including wearables and better access to data that you may not even know exists on you, and make it privately available to you if you wish it, or share it with whoever you wish or desire, that kind of relationship could be very healthy, not just for a healthcare system, but across the ecosystem that we're looking at now. Because most Americans fear AI because they don't see the use case. but show me a couple examples where it's dramatically changing the chance of someone surviving an illness, and you start to change minds. And I'll leave you one example of that. The Mayo Clinic came by the visit, and just looking at routine MRI scans and taking large language model approaches to evaluating the pancreatic tissue of normal, previously read as normal pancreatic scans, they can now detect pancreatic cancer 3 years before otherwise possible. Just looking at subtle little morphologic changes of cells that we never would think would cause an abnormality. Pancreatic cancer is a really bad problem because by the time we find it, it's spread everywhere because you don't see it. It's hidden in the back of your, it's called sweetbread, by the way, if you ever go to a restaurant. But it's hidden in your back behind your stomach. By the time there's a tumor there, no one can tell it's there until it's pretty large and already spread. These kinds of advances change people's minds. I'll give you one other example. If you get checkpoint inhibitors for cancer, having been on antibiotics recently dramatically drops your survival rate. Who would have thought? It does matter what microbiome is in your gut, not only because it changes the efficacy of a chemo regimen, but it allows an immune-based approach to work more effectively because go figure, there are more bacteria in your gut than cells in your body. And we have been ignoring that reality because it was too much to fathom. Now that we have tools that can help us make sense of immense amounts of data, it will be life-saving if we use it correctly. So that's a quick high-level introduction of all the wonderful things that the Working Families Tax Cut legislation brought to us. The Rural Health Transformation Fund is a good example of that. The technology transfer and the openness of this government to consider these options is generational in nature. I hope you are curious enough to look more into the opportunities. Come help us if you desire, or at least spread the wisdom that we're working hard to make the entire delivery of healthcare more effective. Now, obviously, I do very little of this myself. I sit at my desk and look at really smart people who come to help us. Kate Sapra is helping to lead the Rural Health Transformation Fund. Where's Kate? Kate's there she is. I accused Kate of being a flight risk earlier because she couldn't get in the building. So Kate works with Alina Zekai. Alina just had a little baby boy and is happily babysitting him as she gets better from her delivery. And Kate's done a fantastic job. So I think Kate's supposed to come up and speak, if that's okay. Yeah, come on up, Kate. God bless you all.
Dr. Oz is always a very hard act to follow. And thank you all for bearing with us. The traffic on the Beltway was pretty terrible from Baltimore today, but I'm delighted to be with all of you and to talk more about the Rural Health Transformation Program, which, again, I am co-leading along with Alina Zekai. She and baby boy are doing wonderfully. He's 2 months old. He's smiling. So she's right where she's supposed to be, at home with him in upstate New York. So thank you all for being here today. Thank you to Brian and the Connected Health Initiative team for bringing us all together today. Dr. Oz gave you...
One picture. Okay. I promised I'd send this to Alina. She's very jealous.
Oh.
Look happy.
Okay.
Thank you. God bless.
So now I'm going to drill down a little bit further to talk more about what's actually happening in the states on the ground and ways that you all can support states in this incredible mission that they have to transform the way that healthcare is delivered for rural Americans. I'm going to organize my remarks around 3 themes. One is the technology landscape, what states are deploying and the policy actions they're undertaking. Deep dives into telehealth, AI, and the Rural Health Tech Catalyst Fund. And then the design principle that I believe is foundational to all of it. And that is this: rural is not a modifier. It is the starting point. And when we think about technology, for too long, it has been solutions that are taken from an urban context and adapted to rural. And we want to turn that on its head to ensure that the investment that Congress and the Trump administration have made into rural communities fulfills its promise. So that is going to be the organizing themes for the next 20 minutes or so. So let's start with what's actually happening across all 50 states, and we are delighted that this is taking root across all 50 states. We have all 50 participating in telehealth or e-consults. 47 states have some amount of remote patient monitoring. 46 are undertaking EHR modernization, 49 improving data sharing for rural providers, 42 engaging with AI tools to support the rural workforce, 40 with patient engagement platforms, and 35 that are working to improve cybersecurity for rural providers, which, as I've been traveling around, is definitely a concern I've heard from rural providers, because that can potentially put them out of business in addition to putting their friends, their neighbors, their families' health data at risk. And then on the Medicaid policy side, states are also moving. Part of the Rural Health Transformation Program provided financial incentives to states that were willing to move the needle on certain policy actions that would increase access to care for rural communities. All 50 states have Medicaid coverage for live video telehealth. 47 have Medicaid coverage for remote patient monitoring. 38 states cover store and forward telehealth, and 40 states have an in-state licensing exception so that telehealth can be accessed more readily by rural communities. And these are impressive, right? I think what this story tells us is states are engaging in a meaningful way and ensuring that technology is part of the bedrock for rural health transformation. But that's not the whole story. The question isn't whether the technology is installed, but it's whether it's actually being used. And it has to be designed for the people that are using it, in this case, the rural community. And that brings me back to the design principle that you cannot retrofit an urban solution for a rural community and expect it to have the same effectiveness. Rural patients have different connectivity constraints, different care relationships, different cultural contexts, and different distances to travel. So the technology has to be built around those realities and not tacked on afterwards. So I'm going to walk through 4 state examples that illustrate what a rural-first technology design actually looks like. Arizona has one of my favorite telehealth initiatives. They are establishing community-based telehealth access points for behavioral health and substance use disorder treatment. They're standing up telehealth kiosks in libraries, fire districts, tribal chapter houses, community centers, and shelters. Think about the way that they are situating these different kiosks. They're asking, where do rural Arizonans actually live, work, and relate to one another? That's a rural-first design. Then the kiosks will only work if the community health workers, librarians, fire district staff, tribal leadership are trained to support patients that are using it. So technology without a human layer is just hardware and is going to be that virtual coat hanger. And that's not what we want. So we also want to be thinking about the quality improvement aspect of technology. Are patients completing their telehealth sessions? Are referrals being made and followed up on? And the people that are providing the technology can provide that feedback. And I think Brian was mentioning that, the evaluation, really making the training and the quality improvement part of the package that's delivered along with the software. In Iowa, they're deploying a teledentistry model to reach rural communities. They will have 18 portable dental x-ray units in schools that will then have a remote dentist review. Dental staff will collect the x-rays locally, dentists review remotely, and children can then be referred for follow-up care as needed. And that's another great example of meeting patients where they are, in their schools, in their communities, rather than expecting rural families to travel hours for a dental screening. And again, that rural-first design recognizes that, and my family is from rural Iowa, and I'm very excited to be visiting there this summer, but they don't have the opportunity, as Dr. Oz was discussing, to take 90 minutes round trip for a dental screening for their child. Now again, we have to think about the training aspect. Are the school staff or others that are administering the x-rays trained? And what type of training do they need so that the images that come through can be clearly read by the dentist? Again, the QI feedback loop needs to track whether the referred children are actually receiving follow-up care. Otherwise, the screening is incomplete. Idaho, I just got back from there, I was there last week, are expanding telepharmacy networks through remote dispensing models, pharmacy kiosks in pharmacy deserts, prescription lockers, and virtual pharmacist consultations. And these are connected to rural clinics and hospitals. They're also renovating rural pharmacies and outpatient clinics to create spaces for clinical pharmacists to provide chronic disease counseling, medication reconciliation, and prescribing support. Again, this is not a pharmacy app or a medication adherence app, but it's deployed in a small town, working with existing clinicians that have relationships with their community. So the training, again, is important. Everyone needs to know what their role is in the ecosystem, and then they need to have the feedback on what is working and what's not working, how they can improve so that their patients are better served. And then the last state that I'll talk about is Michigan. I promise, my staff came up with these, but I'm from Michigan. That's where I grew up. 40% of adults 65 and older in rural Michigan experience a medical error after hospital discharge. That's unacceptable. My dad is one of those people. He doesn't live technically. It would have been rural 20 years ago, but as we continue to expand our cities, he's in a suburban place now, but he's 72 years old and receives his care in Michigan hospitals. So this one's really near and dear to my heart. So they're expanding home-based care access for rural older adults, coordinating with area agencies on aging, establishing alternative PACE sites, including satellite centers and mobile units, and making sure that they have an age-inclusive telehealth model. And that age-inclusive piece is really important. So they are making sure that the app is designed so that an older user in a rural area can interact with it in a meaningful way. And again, we want to make sure that there's feedback to that it's not just an app, but that it's an app that provides data back to the people that are deploying it, that the states know how they can have better uptake of the app and also better outcomes for the patients that are using it. So next, I'm going to move on to talking a little bit more about AI. Dr. Oz spent a lot of time talking about AI, and its promise in rural health is very exciting. But it also carries real risks if we're not thoughtful and if we're not designing it rural from the start. So I'm going to give you 3 state examples and then talk a little bit more about how important it is that we really train AI on rural communities. And I think we've been considering a lot in the clinical sphere how our predictive modeling is built on the data set and wanting to be really critical about what training data set is used. And that's certainly true when we think about rural America as well. In Maine, they're launching a rural AI hub to develop AI solutions with startups and to expand AI-supported clinical documentation tools in rural primary care. And that's part of reducing the administrative burden that Dr. Oz was talking about. We want to make sure that rural providers, who are very often solo practitioners, have access to technology that's going to make their work more efficient and enable them to spend more time with their patients. In North Dakota, they're using AI-driven predictive analytics within an integrated data platform to identify chronic disease earlier and pair it with at-home monitoring. And that's a powerful combination, identifying the patient at risk and then monitoring them at home so that you can intervene earlier. But again, the design question is, was this model trained on rural patients? Or was it trained in an urban academic center? And then again, we want to make sure that we're providing feedback on whether we are actually identifying patients and getting them into care, whether that remote patient monitoring is actually catching patients earlier, and resulting in fewer ED visits and hospital admissions. And then finally, in Kentucky, they're deploying conversational AI health coaches, AI-powered maternal health monitoring, predictive analytics, and machine learning care navigation tools that integrate with their statewide interoperable health data systems. So that is a lot of technological innovation that's happening in Kentucky, but it's really centered around a mom that's living in a rural area. And this focus on making sure that there is a data infrastructure that surrounds a mom and that it's not just an app, but it's multiple features that all work together, and that data exchange is there so that multiple providers have access to the data that's being generated, will create a more holistic picture of the patient and will also allow anyone who touches the patient to have a more comprehensive picture without asking, again, the patient to go through their whole history every time, which is what Dr. Oz was talking about earlier. And then just the point to make broadly on AI is that AI tools do not deploy themselves and they don't improve themselves. And so we always have to have provider education on the tool. We have to make sure that the patient is educated and that we are monitoring the model. Is it performing as we would expect? If not, is that a signal for us that there is something that is wrong with the way that it was designed? Or is it a signal that's telling us that we're picking up on something new that we should investigate more deeply? And the final part of my remarks today are going to be focused on the Rural Health Tech Catalyst Fund. So this is for a relatively niche audience, but is incredibly exciting. The Rural Health Tech Catalyst Fund provides seed funding to build technology solutions that push boundaries. Specifically, it has to be consumer-facing, technology-driven solutions for chronic disease prevention and management in rural populations. So again, I said it was pretty niche, and there are 8 states that have elected to pursue a Rural Health Tech Catalyst Fund with the RHTP monies. And the focus has to really be on those low-income rural populations, and it has to be focused on using evidence-based measurable interventions to prevent chronic disease or improve management. And it must be significantly different from an existing solution. And so that last point is critical. And we are also going to be looking for emerging companies. Not everyone will be eligible for this seed funding. Organizations that include nonprofits, for-profits, startups, academia, they could be eligible. However, they must be US-based and a US-owned business. And the amount that an individual organization can receive is capped at $3 million. And the funding is also milestone-based. So when an organization wants to unlock additional funding, they have to meet milestones. And so again, this is really focusing on the outcomes that can be produced by technology and providing financial support for those emerging technologies that are going to serve rural America. And there are 2 states that have launched their Rural Health Tech Catalyst Funds, Louisiana and South Carolina. And we have 6 more states that will be coming along behind them. So I'm just going to close really where I opened, and that's really that rural communities have to be the focus of the design and not an afterthought. The design brief has to be how can we build for rural and not how can we adapt to rural. They have different lives. I've now done 2 rural site visits. I'm going on 11, I think, this year. And I have 2 young kids, 3 and 6. So that's not a small feat. But I've been in rural Louisiana and I've been in rural Idaho. And I have talked with the providers there. I have traveled the winding mountainous roads. And it really is a different world. If you haven't had a chance to get out into a rural community, consider this your charge. Take it back. CMS says go see what it's like to deliver care in rural areas. Talk to rural providers. You know, in Idaho, they say QR codes don't work. We've had QR codes for patient surveys, and we got 0 responses. And it's not because our patients don't love us and they're not engaged, they are, but a QR code is not going to work here. So I want to thank all of you for being part of the solution of making sure that rural America has access to high-quality health care. We're going to rely on all of you to bring forward your best ideas in support of our rural communities. And thank you very much for the time. Thanks, Brian, for the invitation.
Well, I believe we're going to remove the podium here. So I'll take this microphone. Whereabouts, Kate, in Michigan? I'm sorry if you just said that, but I also hail from Michigan, so I can connect. Yeah.
Rockford, Michigan. Yeah, it's north of Grand Rapids. That would be our closest city. Perfect. Where are you from?
Big Rapids, Michigan, so
okay,
not far.
That far away.
Right up 131, same highway. How about that?
I was on a panel in the fall, and I was talking with the Michigan Health Secretary, and she was actually from Rockford, Michigan. So health policy is a small world.
Oh, that's glorious. That's excellent. Well, thank you to Dr. Oz. Thank you, Kate, for these remarks. Maybe our panel can head up here as we pull these tables together, and I'll sit on the end. Come on up. Very inspiring, though. I hope you agreed to hear about the vision and how this all fits in at CMS. I just would mention as we're sitting down, I particularly connect with a lot of the discussion about AI. I know that that's something that our community, the CHI, has really been focused on is, trying to advance these principles. I think that were reflected in what you heard: thoughtful design and a shared responsibility for efficacy and safety, and also very interested. I'm going to be looking up more on and if you need more information or I can help getting you information on that Catalyst program, I'd love to do that. But you have heard from CMS and their vision and how it's going so far from their perspective. And now we have a really great panel here of experts, people from different walks. I'll just briefly introduce them by name and title and org, and I'll let them talk a little bit in our maybe first round of questions about who they are and where they come from and their perspective as they answer that question. But closest to me is Dr. Lucy Ide. She is Chief Medical Officer with Health Recovery Solutions. After that is Dr. Tina Yarrington, Division Chief Maternal Fetal Medicine at University of New Mexico School of Medicine. And last but not least, at the end, Kimberly Williams, Director, U.S. State and Local Government and Education Verticals and Strategic Engagement with Amazon Web Services. So, why don't we start? With you, Dr. Hyde. It'd just be great to hear about your path to working on these issues, what HRS does, the patient populations you work with, what kind of opportunities you're seeing and hoping for the country in the Rural Health Transformation Program.
All right. Thanks, Brian, and thank you all for being here today. It's great to be here. So I left clinical medicine about 15 years ago out of the frustration of having no visibility into what happened to patients when they left the hospital or when they left that clinic visit. But this movement of being held accountable as a physician for delivering a better outcome that we had very little control over, right? You write a new prescription, you educate a patient, and you don't know if they're going to walk back in the door in 3 months, 6 months, 24 months. And so I set out I started a company called Remedy that was acquired by Health Recovery Solutions a few months ago. But we share a mission at Health Recovery Solutions to reach those patients where they are, to take healthcare to them, to support that entire patient journey, whether that's when the patient's in the hospital, after discharge from the hospital, or back at home in the community. So this rural health transformation is really near and dear to our heart because these are those patients that are the hardest to reach, who need us, as Dr. Oz said, to bring healthcare to them, right? We've got to stop blaming people for not getting the care they need when it's so hard for them to access care. So super excited about RHTP.
Excellent. Tina, it would be excellent to hear about your background, your role at UNM, the communities you're working with in New Mexico, what you think is at stake for the RHTP, for the especially for the folks you're working with.
I'm a doctor. I take care of people. I'm almost always the odd man out, and I feel like every room I enter. I do high-risk pregnancy care in particular. And honestly, what drew me to move my family and my teenagers to New Mexico was the work I did in Boston, building out, based on feedback from my patients, a remote health monitoring program for women affected by hypertension complications in their pregnancies, who, after they deliver, have a much higher rate of death from cardiovascular disease, rehospitalization, which interrupts bonding with a newborn, ends breastfeeding, incredibly disruptive to families, and also a 20% risk of chronic hypertension in the 2 years after. So this is in your 20s and in your 30s. Based on our patients' feedback and what we learned about the importance of language concordance, about the importance of transportation barriers, we ultimately built out a program that was patient-centered, closed loop, that did reduce readmissions in the 6 weeks, and we're about to publish in the entire year after the pregnancy affected by hypertension. So you can move the needle. And there's increasing data that tight blood pressure control after these complex pregnancies is what reduces chronic hypertension. And so this is a specific population-centered opportunity to reduce the burden of chronic hypertension among mothers, which, I'm sorry, are the core of the family everywhere. And so thinking about how I was one of hundreds of high-risk docs in the Boston area and the implications of rurality, that's why I moved. And I did think, past tense, in my core, that remote health monitoring would be an incredible solution for rural areas. Then when I landed, the barriers are quite different. All the things that we just heard about are true in the day-to-day lives of my patients. And what I do now, I live in Albuquerque, the capital. I don't see any patients in Albuquerque. I'm on the road almost constantly, driving hours each way, and my patients still drive hours to see me. But I do this work because cardiovascular disease is our #1 pregnancy-related cause of mortality, but car accidents are the #1 pregnancy-associated cause of mortality in New Mexico and the states of the Southwest. And so a solution, this is the chance to do a population-wide, patient-centered solution that does not require people to drag themselves into the hospital or the clinic. We need to put healthcare at home. Thank you.
Excellent. Thank you so much. Kimberly, tell us a little bit about your work at AWS, the state and local government partners that you support, others, how rural health fits in, and what you're leaning into with RHTP.
Great, thank you. As you said, I'm Kimberly Williams with Amazon Web Services, and I lead our state and local government, higher education vertical teams, as well as our strategic engagement practice. And what that really means is my team engages with state agencies, with public health organizations, with our health technology partners, and we help them solve problems using technology. And as we heard from Dr. Oz, we heard from Kate Sapra, this is RHTP is the convergence of technology and healthcare in ways we have never seen before. We see it every day in how we bring technology to bear. When you talk about RHTP, it is about provider shortages. It is about limited broadband. It's about behavioral gaps. It's about hospital closures and financial problems. It's about chronic disease burdens, and it's about health deserts. All of those things are not only clinician problems, they are infrastructure problems, and that's what AWS is best at solving.
Great. Well, I have a question for all, but getting at the theme of experiences on the ground, we've already kind of pulled on the thread a little bit, but you know, what trends, for anyone who would like to jump in, what trends are you seeing in 2025 into this year that you weren't seeing 2 or 3 years ago, where, you know, rural digital health adoption is actually accelerating, where it's stuck? Anyone?
Jump in from a technology perspective. I think one of the trends we saw it in 25, we're seeing it again in 26, but this is not something new, is the persistent shortage of healthcare workers. But for the first time, what we are seeing in 2025 and 2026 is how technology can fill those gaps. And they can fill those gaps in ways that they haven't been able to fill before. I think we all remember the early onset of EHRs where doctors were face down typing while they were treating you. With ambient clinical solutions, they're no longer doing that. That's being done in the background. It's increasing the engagement with their patients. It's increasing their ability to pay attention to the details, to actually see what's going on in addition to just hearing what's going on. We're also, I think, seeing some trends around, especially in rural health, how we can bring specialty and subspecialty care into rural health, where before we were just trying to solve it with general health care. And by having the telehealth solutions, by having some of the remote diagnostics, and by really transitioning from more of a reactive way of treating patients to a proactive way, we're actually solving problems through that technology. And those trends are just beginning. I don't think we're seeing the end of those trends. We're just seeing the beginning.
I think another trend that I would hope everyone keeps in mind is while there are fewer doctors, and in my field also fewer midwives, unfortunately, there is a rise in health paraprofessionals. We heard our colleagues speak about clinical pharmacists a moment ago. That would be an incredible clinical anchor for remote health monitoring. You don't need a doctor. You need a clinical pharmacist who knows how to manage antihypertensives, diabetic medications, and so on. Similarly, there's a rise in radiology technicians, ultrasound technicians who can administer the study that can then be linked to your technology and escalate back to the radiologist or the interventional person. But these solutions don't need to be doctor anchored, which is why it's not a very popular opinion among doctors, I realize.
Yeah, I mean, I think we, from a trend point of view, have really seen remote patient monitoring become this core infrastructure capability within healthcare delivery. And it's no longer a pilot. It's no longer actually that innovative, right? Which is a good thing. Now the question is, like, how do we build that full stack solution, right? So we have the technology, it's affordable, it's reliable, but we need this full stack solution of doctors, who there are fewer and fewer of, are sort of at the top of the pyramid, right? And we have all of these other capabilities within that to support them, whether it's clinical pharmacists, community health workers that were mentioned earlier. And we have found with these shortages of workforce, like that also has to be an option to be able to say, you know, I can contract out for technology, I can contract out for services and have a remote nursing group run triage, monitor that high-risk pregnancy population, escalating back to the specialist only what they need to do. So it's sort of this top of license idea across the whole healthcare spectrum. I loved Dr. Oz's call out that they're going to hold states accountable for things like not letting clinical pharmacists practice at top of license, because we have to fix all of that stuff. So from a go forward, I think, you know, taking models that work and repeating them across other states and where there's bureaucracy standing in the way, getting that out of the way.
Great.
Wait, Brian,
Go
I
ahead.
got to interrupt for a sec. This is, I realize, a little bit tangential, but I do want to take exception to the statement that this technology is affordable. It is not. When I went to my state to talk about a remote health monitoring program before this incredibly generous funding came forward, the problem is you can get a blood pressure cuff for $35, $40, and a cell-enabled one is $140. And that is affordable to me, but to triple the cost times that many Medicaid recipients, times that many rural residents, makes it untouchable in rural, poor areas. My ask of all the technology people in the room is please, please come up with a Chromebook of cell-enabled devices, because the cost boxes people out.
Great. Well, that does kind of lead to jump ahead, I guess, in my sequence a little bit. But you know, we're surfacing real-world challenges and gaps here, and friction points. And cost certainly is one, but I just want to make sure. Are there other technical or organizational gaps you see again and again when you stand up maybe roll out a new digital health capability, and you know, how can the RHTP help to give it a positive spin at the end?
Well, I think to add to your point, there is a disparity among technology across the spectrum, right? I think you can look at some of the most advanced EHR systems that are being deployed across some of the largest hospitals and across the largest health systems, and you don't have that same capabilities in rural health. And if you try to share that data, it's not possible today. And you don't have so I think you see some of that being done by old systems versus new technology. You have, what that means also is the experience that patients have too, where their systems are fragmented. They may have multiple scheduling systems, multiple payment portals, multiple ways to view that data. And that that creates a tax and a burden in addition to the burden of already having to drive really far or having to, not be able to get those prescriptions. So I think you see that gap is around a couple of things. One is the access to those applications. And the second thing is the tax that it's putting on the providers in those rural areas using that archaic technology. And we have to close that gap.
And to spin on that, the provider experience of the fragmentation has to do with the various vendors for remote health monitoring information and all these different EHR or non-EHR systems happening, especially in critical access hospitals. For example, in the state of New Mexico, all the MCOs have been asked to provide remote health monitoring, particularly for their pregnant and postpartum patients, and each one uses a different vendor. And I do have an EHR, and I can't integrate 5 different systems into what I do. So I can't even use this opportunity to care for patients better. And so the streamlining and harmonization of how that data comes in and out of that system is going to be a critical step to be able to get to the end product, like Dr. I was saying a moment ago, so that the patient gets the change in their clinical outcome.
Yeah. And maybe just to add to that, because I'm a longtime advocate around interoperability and sort of streamlining these workflows. I think the other friction point, real world challenge we're seeing is sort of the provider and patient literacy around these tools and onboarding. And there's a lot of change management that has to happen with these programs. We're introducing a new way of delivering care. And we see it in programs where a health system decides to do this, but all of their providers aren't even aware that it's happening.
That's
so
secret.
we don't get the referrals to the program that Dr. Yarrington worked so hard to get into place, and then her colleagues, out of no, animus towards you, aren't referring patients. They just don't know it exists, or they don't know which patients are appropriate, or they don't know how to place the order. So that's really boring work at some levels, but it's incredibly important because it becomes a barrier to the patients who can benefit from the program being able to participate. So I think programs like RHTP, where we see things like workforce training, and you're like, what is that? Like, that's what that is. We actually need the funds to educate people that these capabilities exist, because the technology alone doesn't drive the outcome. It's the people using the technology that drives the outcome.
I think there was in the CMS data when you analyze it, it's something like 90% of all of the respondents or all of other states identified the workforce challenge as the biggest challenge. So it's not necessarily the workforce shortage, as you mentioned, it's the workforce education, it's the workforce ability to adapt the technology, to understand the technology, and then be able to measure that of how they apply that to their individual patients. So it becomes much more complex as you roll that out.
I think if we have we have one additional slide that was going to feature the pillars of the RHTP, which is, it's just illustrating what, and this is verbatim from CMS's own release. It's everything you're saying is aligning with it, and so I don't know, of these focus areas with prevention, the areas like prevention, access, workforce, care innovation. Is workforce the most underappreciated, you think? Or is there other maybe bigger opportunities? I'm just throwing out
You
a
can say it.
big
We're
wide
not that
question.
special. There's so many other ways to be healthy.
Yeah.
But the workforce is the underpinning of all of it. The workforce is critical in each of those pillars. They're delivering the service. They are evaluating it. Technology is evolving in ways that we, at a pace that we can't imagine. But when you were talking about the healthcare, and specifically rural healthcare, that human in the loop, whether it's physically in the loop or virtually in the loop, is still the critical part of healthcare. They are the healthcare provider. So I do think the workforce is always going to be the most important thing.
A lot of the state plans are starting there.
Yeah.
I've been monitoring this, trying to figure out, I'm subscribed to 35 listservs and watching all the states. Like, oh, where can I help? Because they're still worried about training their people and making people. I'm going to good news from your viewpoint. A lot of the first round RFPs are all about workforce development and workforce satisfaction, getting the right people in place. They don't want to know for remote monitoring, those are second and third tier concerns, many states. I guess that's good news. So they're looking at our workforce needs to give this. I also was interested cellular enabled blood pressure cuff, you know, how much is being negatively impacted opposed to, well, you got Wi-Fi, you know, other ways to kind of problem that's creating problems for healthcare at home. Sorry, you can't do healthcare at home if like, you know, if you got a dial-up modem, it's just not gonna work. Where is that, you know, sense of that, I guess is all I can ask.
Thank you. Do you all?
Yeah, I mean, and I think if we kind of bring that back to how do we make sure this amazing $50 billion opportunity has a long-lasting effect, right? Because for those of us who've been in the sector for a while and lived through the pandemic era HRSA grants and FCC grants, there was a lot of money that came into the market that paid for equipment that sat in supply rooms or, you know, other, and, you know, so we need to make sure that if there's a gap like broadband access or, you know, and there's an opportunity here to pay for equipment or pay for connectivity, and then there's going to be a cliff at the end of 5 years. I don't think any of us want to see that happen again. So that makes the problem harder to solve because it's easy sometimes to solve a temporary problem by throwing money at it. But, you know, we all lived that a couple of years ago. So, you know, I love Dr. Yarrington's call for like the cheaper, more affordable cellular-enabled blood pressure cuff, right? I think it really challenges us in these communities to think about what is the long-term, sustainable, affordable way that we're bringing connectivity to these patients. Some don't have cell phone towers. They don't have cell phone service at home. You cannot get a signal at some of these patients' homes.
No, in my routine drive out to Farmington, New Mexico, there's a stretch of about an hour with, I can't get a text, much less a phone call or video.
How much of this problem simply because no matter how good a system you have, if the guy handled this combine, cell phone thing, as long as you've got cell phone.
I mean, you hit on the head what perpetuates the inequities for a lot of rural America.
Yeah.
If
Thanks.
I can quick pitch though, just
Please.
because part of what we came to talk about is remote health monitoring, I would actually advocate that application of a population-wide remote health monitoring system could alleviate the burden on individual providers. What I heard from my OB colleagues, physicians, midwives, nurse practitioners, is that the complex care required to do routine postpartum, which includes violence prevention, contraception, birth spacing, bonding, breastfeeding, et cetera, and hypertension care, and asthma, and diabetes, was impossible. And by creating this population program that just took that off their plates, and it was run by one nurse and a fraction of a pharmacist, meant they could focus on those things which are important, and they're important for life, morbidity, and survival. I would empower all of you to talk to your states and wherever you're working to implement better technologies, not to pigeonhole the people problem as a specifically human problem. There are ways to alleviate the workforce burden, stress, and burnout by taking some things off their plate. And when it comes to care for chronic conditions, this can be done on a population level. It does mean that your products can't be these boutique-y things where you have to click into one patient at a time. You really have to flip that so I can look at a population at a time. But it would be a huge gift to providers.
Great. Well, we've pulled on the sustainability thread a little bit. Just if there's anything more to add to that, I was thinking about new capabilities digital health brings. 5 years ago, 10 years ago, how can we hammer on this sustainability? Clearly, it's important to CMS, as we heard, and I think the program is structured that way. But I just wanted to be sure that there's not anything more on this sustainability topic that anyone wanted to add.
I'll just make a quick comment about it. So when we talk about sustainability, we just talked about how the technology is archaic in some of these places and they're behind. But what is going to make this sustainable is the ability for them to move forward. When we look at updating, when you look at a rural health community that was able to update their EHR in general, there was a 60% decrease in radiology scheduling backup. They're getting care faster. There's 20% improvement in diagnostic imaging utilization. The outcome is better. There's a 50% drop in the number of patients that were abandoning their calls, giving up on it. That creates sustainability because you are going to increase the outcomes. We have to change that. I mean, the sustainability is going to come in how we measure different outcomes. We used to look at technology projects and be like, we bought technology input, and that's an input, and we would move on. Or we'd say, oh wow, did it actually go live? Because there's such a high failure rate of technology. Now we have to look at, did it actually get implemented? Then we have to look at the utilization around it. And that's what RHTP is actually promising, that ability to go down that list and say, did we buy it? Did we implement it? Is it being utilized? Is it being adapted? Is it creating the outcomes? Is it being equitable? Are we reaching people, and are we reaching all the people and all the, and each population within those? And so I do think the sustainability comes from the success, and the success will breed the success, and the change in mindset in a lot of ways, the first time around just, here's the money, go implement something, here's your input, and go away. That's not where RHTP is focused. It's focused on the outputs and the outcomes.
Yeah, and maybe just to tie it back to when Brian opened and mentioned these outcomes, I think there really is the onus is on all of us to capture and demonstrate the outcomes and the impact. And there is a future state, as Dr. Yarrington was saying, where the physician shortage, nurse shortage aren't the hindering factor because we figure out how to deliver care more efficiently. And I've done a lot of work in diabetes management. I speak with a lot of endocrinologists at large, academic medical centers who say it's an 18 to 24-month wait to get in to see them. Like, what good does that do if you have a medical problem and it takes 18 to 24 months to get in to see somebody? So we've got to sort of fix the upstream, right? So that only the patients who really need that super specialist endocrinologist at Northwestern are getting in to see him. And the people who don't need that level of care, but how does that patient know, right, are getting cared for by somebody else in the ecosystem. And, standardizing on like remote monitoring, identifying the level of care needed for certain patients helps unlock some of this capacity issue that we're having today because we sort of reimagine how we navigate care for patients.
Great. Well, I had maybe one more question, and then we have a little period here at the end for any more questions from you all out there. I already appreciate the engagement there already. But just to maybe think about moving forward and tracking success, like you were just saying, it is critical. I mean, obviously, you can tell we think it's critical. The Connected Health Initiative, we developed this, the start of a framework, but I think we're probably all of us are probably going to generate an enormous amount of evidence, real world evidence about what's working and not working in these rural communities. And I don't know if there were any more details that people wanted to share about what should be captured, whether it's thematic or a specific measurement or something in between. And if you see, because my hope, this is a long wind-up and a leading question, I fully recognize that, but I'm really hopeful, and I'm curious if I'm maybe being a little too optimistic here, that that what's going to be generated from this program will provide a great evidence base for any state Medicaid authority as they consider new allowances. They got to be very careful with new allowances. I totally understand that. But this might be able, that's getting sort of into the legacy and moving forward. But I don't know if there's any particular theme or specific measurement that you all might want to throw out there. But also, do you see that potential? Or maybe is that on the radar of states so far that this program, I mean, clearly they've got the money, as we've heard, and they're putting the grants out and awarding the grants. But is that an opportunity you also see? Very long question.
I'll tell you one really specific thing I'm hoping we see out of this is that there had been a problem until 2024 that Medicare would not pay for remote patient monitoring by rural health clinics and by federally qualified health centers. Like if you were a Medicare beneficiary and you got care anywhere else, you were eligible for remote patient monitoring, but not if your provider happened to be a rural health clinic or federally qualified health center. And that got changed. That is still the case in many states' Medicaid plan design, which makes no sense, right? They're patients who have the hardest time accessing care, who might have no other health care in their community other than their rural health clinic. That rural health clinic cannot be reimbursed for providing remote patient monitoring. I would sure hope that the evidence gathered through RHTP is what the states are going to use to make that policy change to prove that they can deliver a better outcome at a lower cost. So if we don't answer that question, what are we doing?
True.
I would love this to be an opportunity to be able to triage everybody if we're going to really talk pie in the sky. One of the downstream effects of the distance you have to travel to see a provider and the lack of a provider there and the fact that hospitals probably closed by now. I've been in the state for 3 years and 3 maternity centers have closed already, just shrinking every day. But when the person presents with a heart attack, that should not rather be when they're diagnosed with hypertension. That hypertension was there for years and led to a heart attack because it was uncared for. And the person who presents with blindness, that is not the day they should be diagnosed with diabetes. And so the opportunity to touch in a patient-centered, outside of the brick and mortar hospital or clinic way, every patient across this rural diaspora and get a blood pressure, get an A1C, get lipids, get just the basics of screening healthcare will give the opportunity to triage the population. Because maybe not everybody needs a doctor's visit, but some of them do. I also do want to call out the weakness of this triage approach, and that's the epidemic of behavioral health disorders, depression, suicidality, and so on. I am very concerned that if the solution for rural health on a population level is to triage these chronic conditions and decrease the people that we ask to make that one-on-one contact, that we will never build the trust necessary to disclose thoughts of self-harm or harm to others. And I don't pretend to know the solution to that.
I think one of the things that we're really paying attention to is, the heroes that go behind this, which all the healthcare workers that are there trying to implement this. What we are seeing, the early results of some of this technology and AI in particular being used to alleviate some of the administrative burden on them, is that early indications are that burnout rates are dropping from 69% to 24% in months, not taking years for this impact to be made. And that's going to make a huge difference, not only on them, but on the patients they care for and their ability to care for more. I don't think we can, forget about, again, this workforce issue keeps coming up in every pillar. But one of the, I think, shining stars of this is the ability to reduce that burnout rate and really empower and enable them in ways we haven't been able to.
That's a great statistic about burnout. I just add too, if I could, I'm excited about, I think that the administrative and back-end use cases for AI are clear, and it seems like there's some great value being demonstrated right now. All that's kind of provided by the advent of cloud computing and the infrastructure the country's built out, and that's a whole nother panel and a whole nother issue that I'm sure you're all somewhat familiar with. But also the AI use cases that are getting closer to the point of care are really interesting to me, supporting a clinical decision being made. There's some interesting use cases I'd urge people to read up and take a look at it, that past what's already been mentioned from previous speakers too, diabetic retinopathy and things like that. Some of these things have some great demonstrated value. That was my little non sequitur there, sorry. Had to say that. So does anyone have any questions that maybe haven't been asked already? Anyone? Yes. Thank you. Anyone have any thoughts on parity?
I mean, we've seen it with remote patient monitoring that if it's being billed under a nurse practitioner versus a physician, right, there's usually a lower payment rate. And the structure of those fee-for-service payments are such that you don't have 20% wiggle room in there. So I think all of that needs to be rethought. I mean, I think part of the solution is to getting to outcomes-based payments, not these transactional fee-for-service-based payments, because then who cares how the care is being delivered or who's delivering the care? You're paying for the outcome.
Great. Well, I recognize we're kind of out of time here. This is really, oh, yes, please. We do have.
Christian Master, there's an invisible elephant in the room, and that is change management. A lot of people have talked about it. We talk about broadband shortages. I just looked it up. 99% of rural failure access. Right? Coverage loss doesn't mean that they don't be at parity. A lot of insurers pay at parity. But the biggest problem that nobody talks about is that health organizations are good at running things, keeping the door open, putting it together, but they're not very good at launching. This is what it's called for. Yeah. It's not just building technology, right? We have technology companies and RPM companies, like our guides here, that do a good job getting it to the doorstep, setting it up, and training some. But there is so much more of engagement that needs to be handled. And so where is the funding? Where's the awareness that we need to really educate these rural clinics and rural operators on project management, on change management? And yes, not making it rural specific and hiring rural people. Implemented telehealth in 25 states in the last 15 years. This is, I know its rule is very, very, very different. That's what we need to have more awareness. Technology is great, I'm an engineer, but we need to apply it.
Thank you.
Respectfully, rural providers are not bad at any of that. They are working their asses off to take care of the people that are pouring in the doors all the time. The point is well taken, however, when I think of the rapidity that's being asked for of this administration, because change management takes time in any space, particularly one that doesn't have any administrative wiggle room. The critical access hospitals across New Mexico do not participate in QI. They don't submit data anywhere. There is high turnover from locums physicians, et cetera. The leadership is never sustainable. And so there's a real chance this will fail because they won't be able to change fast enough to show the clinical outcomes being asked of by the administration. And the solution there isn't to train them more. I think there is a path, but it's to send people there to pay for additional staff to take on this burden because the nurse can't do it, and the administrator can't do it, and the docs can't do it.
Thank you for raising that. Yeah. Well, we are at time. So I just want to say thank you to Dr. Oz, to Kate Zapra, and to our esteemed panelists here. Thank you all for joining us today.